we need the speakers to set up before you, so we're going to have a break between, and they're going to have to use this, and then we'll
I
connect
think we
yours
can just
again.
swap this out. We should.
Okay. Okay.
No, it shouldn't. It should take in, but there it's blocked.
No.
This is connected to
They need it before you.
You need?
Yes,
This
they're
part.
the presenters, the keynote speakers, so they need to present before you. So we need to take it out, and then when they're done, we'll put yours back in. Okay?
Yeah.
So this plug right here.
Because do you need
Either way,
this
we
one?
have this too. He has
Yeah,
one.
is that yours?
That's mine, yeah.
Okay, so then take that and they'll use
We'll just
theirs.
go here.
I'm going to put this over where it needs to be.
Okay, and I have here the stuff for both.
Okay, that's fine. Thank you.
That's fine.
What we can do is put this down here.
Yeah.
We'll set her computer down here.
Yeah, that's fine.
Yeah, it's okay. Okay to set it down here?
Yeah, because
We'll
don't
just let it
shut
go.
it down. Just
No.
keep it like.
We just keep it like it is. Is that
That's
okay?
That's
All right, good. I think that needs to be turned on. Hi. Was your presentation playing?
Well, it are some pictures.
Looks okay. Okay.
It are pictures
Huh?
scrolling over with the text.
It's up to you. I think I'll do this, and then you can. Hang on. Yeah. Yes.
May I ask something?
Yes, please.
If you are finished with this,
I can plug it back into yours.
if you can
Oh,
do it,
easy.
because it could take maybe a while. I don't know.
Happy to do it. What time is your presentation?
After
After ours.
About what
after it,
approximately what time?
around 8,
Whenever.
8ish? Yeah. As soon as I
switch
finish,
as soon as we're
we'll switch it out.
because then she will introduce me the time she's in. It would be nice
Good.
if it's.
Did you check out to make sure yours is playing? Yours
Yeah.
was showing? Okay.
Yeah.
Good. And then you're in
But
good shape.
that's I'm afraid to that he would without.
I'll help you. Don't
because-
worry.
Because this is the one I should play.
Yep.
It's a movie that came in by email.
By email. Okay.
So I couldn't make it on my iTunes.
I knew iTunes.
It's
Okay.
a movie I made on my other MacBook, and normally it should be synchronized, and it didn't do this.
Is it playing on here?
Here
And
on
it's
this slide-
playing on there
yeah,
as well.
Yeah, that's
Very good.
that.
So we'll just keep it up there. If it goes to sleep, that's okay. You can just hit any button and come
yeah,
back on.
yeah. So, but
Yeah, it'll be
just-
fine.
I don't want to disconnect.
Disconnect it.
That's it.
Yeah, exactly.
To be sure.
Right.
Because computers is good.
Yes.
But they could
So
be
put
very
it away in
annoying.
the side,
Yeah.
away, and then
So
we'll just
if
leave
you
it there.
Put it in there, then I only have to
Yeah.
start.
Yeah. Yeah, it'll be easy. No problem.
Thank you.
Yeah, no problem.
Okay. we become famous.
Fine.
We have good publicity, you know.
Supposedly
MSA.
we are live.
Well, could you say rich?
Richa? For me, Richa?
It's Rita, but a little Rita.
I'll try. I'm very bad with Richa.
From Amsterdam.
But MSA, how do you...
EMS is
Yes, it's Amsterdam, but this is Spain.
So,
Systeem.
and you're from Belgium. Okay.
so I need to know the pronunciation right. A few years ago, yeah. Shupa? Yes, Shupa.
mine is here, and he's
Just leave it like that.
and he's still on. So what they're gonna do is, he has finished. He's gonna this hat, and in the meantime, she's introducing me. It should be okay. So it's still. I didn't change it.
Everything is gonna be okay.
But
Just
anyhow,
relax.
I know you are a good guardian angel. You will be around.
I'll be around, okay? Everything's gonna be fine.
Because once they plug in, people will see my screen, I suppose.
No, they don't see
If
anything.
they are finished,
When they finish, I'm gonna be right here. We just unplug
then
it.
I asked to plug it in just to, yeah. Because if she's calling me, I can't be in front before she's calling me.
I have my own because I want to make sure that you guys have one. But
Yeah.
I
Well,
got
I
one.
have this one, I have the other one for my iPad because it's still different. But it's good. I'm very pleased with your service.
I'm gonna show you a picture. That look like you.
It's not me.
It's not you, but it's a pretty thing.
That's true. That's true. Okay. Thank you, Elliot.
When I saw you, I said, "Boy, she looks like my wife." Okay, so yeah, I'll
So
be here.
he's still on, so
What time they gonna start though? Because they told me at 6 o'clock. It's
yeah,
already
but
6:20.
that's the meal, and after that at 8 o'clock there should be the candle lighting, and I'm
Alright.
supposed to open that. That
Alright.
means the other guys.
So the
should
dinner is at
already
6
have-
o'clock, but the presentation is at 8 o'clock.
Yeah.
All right, so bon appetit.
Good evening, everyone. Is it on? Good evening, everyone. How's everybody doing? Okay. My name is Judy Biedenharn, and I am the chairman of the board of directors of the Multiple System Atrophy Coalition. I want to welcome all of you to New Orleans, and hopefully you're going to learn a lot, but make a lot of new friends. I'm going to keep my welcome very short. We're probably all starving to death. I know the board members are because I don't think any of us had lunch today, but there is a welcome letter in the notebooks that you're going to be getting, so if you'll take some time to read that at some point before the meeting tomorrow. We're going to spend about 45 minutes eating, and then we're going to have Dr. Kamani and Dr. Vernino be our speakers for this evening. So right now, without further ado, I'd just like us all to bow our heads for a moment of thanksgiving to our Heavenly Father for all the food and for the physicians that treat MSA patients, the caregivers, and for strength to take this journey together, and ask that He give us a cure for MSA in our lifetimes. So God bless our food. Amen. So now, the food is set up out in the hallway, so help yourselves, and then around 7 o'clock we'll start the talks. Thank you.
And a mad dash, everybody jumps up.
Good evening again. Okay, we're getting about ready to start the presentations. Thank you, thank you. I meant to wear this before to welcome you all, and I forgot I had it in my purse. So this is what New Orleans really looks like. I can do anything here, and nobody will know it was me. Okay. But again, welcome. I hope you all enjoyed the dinner. Typically, in the last couple of years, we have had a candle lighting ceremony, and we're going to be ending this evening with that. But along with that, I'm going to bring Cindy up and let her explain just on a couple words. But before she starts talking about, is that better? Before she starts talking about the candlelight ceremony, she has done 90% of the work on this conference. So Cindy Romer, I think she deserves a big round of applause. If she knew I was going to do that, she would not have been around. So get on up here, Cindy.
Very true.
So thank you, dear.
And we work as a team. It takes a village for this group too.
Thank you.
So regarding the candle lighting session later, I'll come back and we'll talk a bit more about it. We have a facilitator that's here tonight, a very special guest that's here tonight. But just to give you a little bit of a brief background, we've started doing this a couple of years ago, connected to World MSA Day. So basically, you're going to have the opportunity to light a candle. It could be in memory of someone you've lost to MSA. It could be an acknowledgement and an honor of someone that's currently dealing with this journey, this MSA journey. So over the next few minutes, some of the volunteers here will be walking around with little cards so that you can write your little note of dedication, the person's name, and any note that you want to say in preparation for the ceremony later, so that when you go up to light the candles, they'll be ready to go. Okay, so just so you know what's going on when some people are walking around with those cards. Okay, so more on that later.
Okay. Thanks, Cindy. And one other thing before I forget, we passed out some evaluations earlier today, but people have kind of drifted in and out. So if you did not get an evaluation form to fill out to rate all of the programs this afternoon and all of those tomorrow, make sure tomorrow morning that you do get one of those, because we really value your feedback. Now this evening we've got two wonderful speakers that I'm going to introduce to you. They're going to kind of tag team it. It's Dr. Pravin Kamani and Stephen Vernino, and they're from the University of Texas Southwestern. So now it's time to get a little serious, so I'm taking off my New Orleans do, and thanks. We're going to just hear all about Centers of Excellence from these two marvelous physicians, and we do thank them in advance for giving their time to fly in to talk with you gals tonight. Thank you.
Well, thank you very much. I'm going to stand over here. He gets his computer working. Well, it's really a great pleasure and honor to be here. And we're going to tell you a little bit about some of the work we've been doing at UT Southwestern in Dallas, and how we got to this point and where we think we're going in terms of developing some multidisciplinary centers of excellence, not just in Dallas, but as a blueprint for perhaps how we can advance the care of patients with multiple system atrophy. And I'll say right from the outset that a lot of the lessons we've learned have not been ones we picked up in medical school or residency, but we learned from our patients who've basically told us what it is that patients with MSA and what their caregivers need. Okay, I was just sort of rambling while he gets the computer working. But basically I was saying that the idea of Centers of Excellence really came out of the idea that we learned from our patients that there were things that the standard medical visit or neurologic visit with the neurologist just wasn't accomplishing. Issues that the caregivers had, that the patients had, and many of our patients came from a long distance to see us, and then needed 3 or 4 or 5 appointments, and it was very difficult to get all that together in one day. We came up with a concept that really borrowed from other disease entities. So for example, in patients who have ALS or Lou Gehrig's disease, they need to see a neurologist and a physical therapist and a pulmonary doctor and so on. Patients with muscular dystrophy sort of need the same thing. The concept of a center of excellence is not new, but we wanted to try to learn some lessons from our patients and then bring this concept to the multiple system atrophy patients and their caregivers. All right, awesome. Look at that.
Do the slideshow to the presenter view. Is that good?
Yep. Okay. So I'll start off. We're sort of partners in crime here. I trained as a autonomic expert under Dr. Lowe and his colleagues up at the Mayo Clinic. So I got interested in multiple system atrophy from the standpoint of blood pressure regulation and bowel and bladder dysfunction. I really don't know much about Parkinson's disease or ataxia. But Dr. Kamani, who trained in movement disorders at Stanford, is an expert in Parkinson's disease and has a long interest in ataxia. So just an example of how we can put our heads together and come up with something, hopefully that the sum is greater than, or the whole is greater than the sum, however you say that. Okay, so just getting into what we're going to talk about today, very briefly about what is MSA, because this is not an audience that needs to know that. But really, what is the Center of Excellence? How does it apply to MSA? Why it would be a good idea to have an MSA Center of Excellence? And then what is our center? What does it look like? And what can we do to advance this cause? So very briefly, you all know this, but MSA is a relentless neurodegenerative disease, but it's unique among neurologic disorders in that it affects multiple neurologic systems, hence the term multiple system atrophy. It's autonomic function, cerebellar function, basal ganglia function, which is where you get the Parkinsonism from, corticospinal tracts, those are the parts of the nervous system that control stiffness and movement, but also the brainstem, which affects sleep and breathing, but usually not the cortex, that's the thinking part of the brain. And so in some ways, all of the body is kind of going to hell, but the ability for the patient to understand what's going on is preserved, unlike some other diseases like Alzheimer's disease. So this leads to the problem that it's a multiple system disorder, and one neurologist may be very good at treating autonomic disorders, and another may be very good at treating Parkinson's disease, and then they lack sort of the skills to manage some of the other problems that patients get into. So the symptoms, as you all know, include autonomic symptoms like orthostatic hypotension and constipation and bladder dysfunction, disorders of sleep, REM sleep behavior disorder, swallowing difficulty. Pseudobulbar affect has to do with the regulation of emotion that gets very up and down with patients who have neurodegenerative disease, and often misdiagnosed as severe depression rather than a consequence of the actual disease. Pain and discomfort, we were just talking about this a few hours ago, how we don't really understand where pain and discomfort comes from, but it's certainly a feature of the disease. And then dementia, well, not really dementia, but also breathing problems as the disease progresses. So how do patients show up? And this is the problem. Patients show up in a lot of different ways, and it can be difficult for your general neurologist or your primary care physician to really get the idea of what's going on. So many patients present with poor balance, but that can be due to a lot of different things, and often patients are diagnosed as having just poor balance from getting old or Parkinson's disease. But what's different about MSA is that the typical treatments for Parkinson's disease don't really work that well. So that's one clue that maybe we're dealing with something different. And then some patients present with cerebellar signs, that the balance trouble, the speech slurring and so on, and can be misdiagnosed as having a stroke perhaps, or being an alcoholic in some cases, which leads down a different pathway. Strange movements and stiffness of the muscles or abnormal postures, and then troubles with weakness and balance difficulties and so on. Stridor refers to the abnormal breathing that a lot of patients with MSA get. So sometimes patients present with primarily sleep problems, misbehaving at night and having noisy breathing. And it may show up in a sleep clinic and get put on a CPAP mask for sleep apnea. And again, all these things, if they're looked at in isolation, may lead to the wrong diagnosis or delay in making the right diagnosis. And then eventually, all of this conspires to rob people of their ability to be mobile and perform the activities of daily living. So what do we know about MSA so far? Well, we know it's caused by this protein alpha-synuclein that collects in the supporting cells in the brain called the glia. This is just a picture of actually one of my patients who died and had a brain autopsy, and they used the stain for alpha-synuclein that lights up pink right there, and you can see how the alpha-synuclein is spread all over the brain tissue. But if you look louder still, I sound pretty loud up here. Okay. But it collects in these glial cells, which are the supporting cells of the neurons. And eventually those glial cells are actually very important for how the neurons function. So what's interesting is that alpha-synuclein is not a foreign protein that somehow gets into the brain from outer space or something. It's a normal brain protein that is involved in a number of different diseases. We honestly don't know precisely what it's doing in the brain. Presumably it's there because it has a normal function. And we would not want to be without it. But in Parkinson's disease and diffuse Lewy body disease, it starts to build up in neurons, and those are called Lewy bodies. But in multiple system atrophy, it collects in the glial cells in something called glial cytoplasmic inclusions, or GCIs. That's what the pathologist looks for. So although it can be very difficult during life, in some cases, to separate Parkinson's disease or diffuse Lewy body disease from MSA, the pathologist can do that very well. Unfortunately, we don't need a pathologist till much later in the disease. So what's interesting is that once started, this collection of alpha-synuclein collections, it can spread. And this is some of the work that you may have heard about over the last couple of years in thinking about alpha-synuclein as a quote-unquote prion, or a protein that kind of infects the brain and spreads around. And there's some data that's how it happens. It starts in one place, which may be the first symptom, depending on whether it starts in the brainstem or the autonomic nerves or in the basal ganglia, and then the alpha-synuclein can spread to other areas, leading to different symptoms getting involved. But we don't know what starts the process, and we're just now scratching the surface about how this spreading happens, but there's a lot of scientists working on that. Okay, it's getting louder now. So there's a lot of research efforts going on focused on the pathophysiology, and that's great, and you'll probably hear a lot about that this weekend, about what kind of genetic and environmental factors are there, what kind of drug therapies might be available, but I'm going to leave a lot of that for the other experts. We're also doing better at developing techniques to get the diagnosis right earlier, using things like biomarkers that can help differentiate multiple system atrophy from Parkinson's and other mimics. But why is that important? These are all diseases that we can't fix, but hopefully that's going to change. And if it changes to the point where we have a treatment for Parkinson's disease, or we have a different treatment for multiple system atrophy, then we as physicians need to be much better at making the correct diagnosis. So new treatments are going to be guided by the scientific breakthroughs in the animal models, and hopefully then applied to patients. And just to remind you that it can be difficult to make this diagnosis, and it can be difficult to make it early. As time goes by, we as experts who see a lot of MSA can make the diagnosis with fairly good certainty, but often even the best experts can't make the diagnosis when the patient first shows up in our clinic. But we can have a suspicion and call it possible MSA, but that may be 8 or more years before death, and maybe many years before we can make a diagnosis of probable MSA. So we got to figure out better ways to diagnose possible MSA, because we don't want to wait till it's definite MSA, because that's when the cat's out of the bag, so to speak, and the pathologist is getting involved. So we'd like to be able to make a definite diagnosis early and apply treatments, and that will come. But we realize from our patients that there are some needs that are already issues, and I think this is the point where Dr. Kamani was going to come up and tell us a little bit more about the idea of a multidisciplinary center and how that can start helping patients with MSA now, before we even have therapies that can alter the course of the disease.
Thank you, Dr. Bernino, and thank you all for having me here tonight. Can everybody hear me okay in the back? Yeah? Oh, great. Thumbs up. Fantastic. It's really an honor. I see some familiar faces, some of my patients, and it's great to be here and do this talk with Dr. Bernino. So a little bit of my background is when I started at UT Southwestern 5 years ago, I was seeing a whole variety of movement disorders patients, including a lot of patients with ataxia, and that's one of my areas of interest. Ataxia is a complicated disease, and there's not a cure for a lot of ataxias, and if you follow ataxias over time, about 50% of ataxias that do not have a name or a cure evolve into MSAC, the cerebellar type of multiple system atrophy. So I kind of fell into the treatment of multiple system atrophy through the ataxia route. And of course, there was a significant number of people with the Parkinsonian variety as well. So Dr. Bernino, who works across the hall from me, who has been treating this condition for a long time, we sort of matched up our efforts, and we thought we could collaborate in the treatment of patients with multiple system atrophy, him with his autonomics expertise, and I with my movement disorders expertise. When there was a sufficient number of people in the clinic with this debilitating and terrible condition, I recognized how complex the management of this condition is. In order to render effective treatment, you need a group of experts to come together, because truly the disease involves multiple systems and one specialist cannot do it all. And I certainly realize the challenges. And upon speaking with the patients, it was evident that a clinic, a multidisciplinary clinic or a center of excellence was needed to meet some of the unmet needs of clinical care, education, and research in multiple system atrophy. So that's sort of part of how we started this journey to form a clinical center of excellence. So to reiterate some of the stuff that you already know, multiple system atrophy involves the neurological pathways that cause significant problems with mobility, but also those pathways that cause blood pressure problems, urinary problems, and which together can rob a patient of his or her mobility. It seems like the experts that are involved in the care of a typical multiple system atrophy patient include a neurologist, a cardiologist to manage complex up and down blood pressures, a urologist to help with the management of a bladder that is not either emptying or storing urine appropriately. As we heard, MSA can cause problems with sleep and breathing. REM behavior disorder is a condition in which you act your dreams out at night, can be pretty violent, but even more troublesome are breathing problems that occur at night, which cause stridor or the vocal cords to collapse or close. Gastrointestinal problems, including constipation, slow motility of the gut is a problem in multiple system atrophy. Vocal cords being affected, otolaryngologists are involved at either at the middle or the later stages of multiple system atrophy to see if the vocal cords are functioning well. Physical medicine and rehabilitation experts are needed to ensure appropriate physical therapy, occupational therapy, speech therapy is being provided at various stages of the disease. The role of a nurse or of a nurse coordinator is absolutely critical in helping the patient and family members navigate the system. Palliative care becomes important at certain points of the disease. Emotional support is critical for the patient and the family, and social work support is really important. And a lot of these needs were identified by patients in our clinic, not just the medical, but the emotional needs of patients and families as well. So, basically, due to these urgent unmet needs, we decided to collaborate with our colleagues in various departments and try to bring as many specialists as was practically possible into one space in the clinic to provide for patients and families. And the urgent unmet needs were difficulty navigating the system. It may sound like a non-medical concern, but truly, when you have to see 6 experts and have to make 6 trips to the clinic, it becomes extremely burdensome. And there is not a nurse, or if there's not a nurse or nurse coordinator helping the patient and the family navigate the healthcare system, for instance, in our university, that adds to patient and caregiver burden and can potentially impact quality of life. And this is what we heard firsthand from our patients. Navigating insurance, don't even let us get started. It's just a nightmare, and I'm sure everyone has a story about that. A quality of life and caregiver burden that I've alluded to. A delayed diagnosis. This comes up in every conversation about MSA, is why did I have to spend 4 years trying to get a diagnosis and run from pillar to post? So that ties into appropriate education of doctors of tomorrow, next generation doctors, or coming to the expert and getting the diagnosis early on, saving resources, not doing unnecessary tests and procedures. That is a common complaint we heard. Integrated care, which is integrating all of these resources together, the specialist as well as the social worker, to provide comprehensive care, which is a definition of multidisciplinary care. And of course, the holy grail, which is research and development towards a cure. That becomes important, and we need a sizable population of patients to do research trials with and to implement therapies in order to move in that direction. So those were the urgent unmet needs, which sound universal for a lot of the neurodegenerative diseases, but these we found were specific to our patient population and our clinic as well. We had all these building blocks in place in our center, but they were sort of fragmented and fractionated. And what we wanted to do was sort of bring them all together under one umbrella and coordinate a care. And therein was the vision of the multidisciplinary MSA Center of Excellence. I will show you a timeline later on, which illustrates that a lot of reconnaissance and investigation went into developing our Center of Excellence. So we looked at several models that were already out there for centers of excellence. Although there was not one for multiple system atrophy, there was a Huntington disease Center of Excellence model, there's a Parkinson disease Center of Excellence model, there is a multiple sclerosis Center of Excellence model that is primarily run by the VA hospital. There's an epilepsy Center of Excellence model that is also run by the VA hospital. There is a well-known MDA-sponsored ALS Center of Excellence model, and there was a wonderful clinic that's been in existence for over a decade run by Nir Giladi and Orna Moore in Israel. It's the Tel Aviv Neurodegenerative Multidisciplinary Clinic. And so we wanted to know, what are the components of a Center of Excellence? What are the models out there so we could adapt what was going on in these various centers to our clinic? And this is just an example, and you may not be able to read it, and that's okay. It just gives you an idea of what integrated care is, where each component is talking to each other. And right at the center of this particular model is the nurse specialist. a nurse coordinator that is keeping the lines of communication open between the various components and between the various subspecialists. And that is a very important part of any multidisciplinary center or center of excellence, that people need to be able to communicate together, to communicate with each other and come together to formulate a plan for the patient and the family. And when I was doing research on other neurodegenerative clinics, I really have to give a shout out to the center they have at UNC, which is the Interdisciplinary Parkinson's Clinic, specific to Parkinson's disease, but they see other neurodegenerative diseases in that particular center. And Jessica Katz, who's the social worker out there, helped me significantly in understanding what integrated care was in neurodegenerative diseases. So a lot of investigation went into development of the center. And my own experiences at UT Southwestern when I was a neuromuscular fellow in the ALS clinic helped inform our Center of Excellence. And then I also worked at a center with Jeff Rosenfeld at Carolinas Medical Center, which was an ALS and neuromuscular center. And we realized that there were these common elements in all these centers of excellence, so that it became clearer and clearer what a center of excellence needed to be. A center of excellence basically needs to have a clear mission and objectives. Experts that include MDs, nurse practitioners, PAs, and a staff that are dedicated to the treatment of the disease. There needs to be obviously space available for getting people together and providers together in the same space that takes up a room. There needs to be an appropriate budget because traditional mechanisms of healthcare delivery do not pay for a lot of these components. For instance, social work is not paid by insurance unless you're doing clinical counseling. So we needed a budget for someone to pay for social work counseling for our patients. A nutritionist is not paid for by insurance. And so we need to have a mechanism of funding these services. There needs to be an educational core to centers of excellence, a research core, which is absolutely critical. What are the research goals of the center? The primary goal being clinical care, but research needs to be tied to that to move the field forward. What are the outcomes? You need to be able to measure outcomes from a center of excellence, and it needs to be an iterative process in which, when you look at the outcome, if it's a good outcome, you continue doing what you're doing, and if the outcome is not great, then you go back and you go back to the drawing board and change things that are not working. And outcomes could include research outcomes, educational outcomes, but most importantly, feedback from patients and caregivers. Is what is working in the center and what is not working, because truly the Center of Excellence is for patients and families. A database, this is very important, is what data are we gathering and collecting over time? Can we look back at it and see what we learn from our data? And we are in the era of big data. The database we have currently is excellent, and it's used to document diagnoses, autonomic features of the disease, blood pressures, etc., quality of life scales, depression. So that's very important, because you can that would be used to derive your outcomes. A center of excellence, any multidisciplinary clinic, needs to be sustainable, and for that we need continuous funding, which is tied together. So we already had a mission, and this mission was informed by our patients. Is what are you going to do to improve the quality of life of patients and caregivers? So our primary mission was to improve the quality of life of patients and family members affected by multiple system atrophy through the provision of multidisciplinary care. The objectives were more concrete: to provide excellent clinical care, to train the doctors of tomorrow, and also the community physicians, family practice doctors, neurologists, etc., to identify MSA early and to refer them to the specialist on time to prevent delayed diagnosis. And research in terms of outcomes, research in terms of pharmaceutical therapy, research in terms of any other needs, unmet needs of the clinic, whether medical or emotional, which would be data gathering and then analysis of data. And I'll show you a couple slides from our first year running this clinic. Clinical experts and staff, we already had them. All we needed to do was bring them together. So it seems like we had all the building blocks. In our current MSA Center of Excellence, we have neurologists, nurses, social workers providing the emotional support, and physical medicine and rehab doctors that form the core of the Center of Excellence. The other services are available on campus promptly, but not within the clinic. And the reason is practicality. You cannot have a clinic with 8 or 9 or 10 doctors. The visits are going to last forever, and these visits can be extremely tiring. So you got to balance it with the core needs and then supplement the remaining needs through the provision of care outside of the clinic. We had the space, we had a research and an educational mission, and we knew what outcomes we needed to track. The primary research outcomes in the first year were to study the quality of life in MSA patients, to identify what most people complained about most, or what were the factors affecting quality of life most. In addition, what we wanted to do absolutely was to look at the burden index of caregivers. It's not been very well studied in various neurodegenerative diseases, but there are a couple scales that are validated that are available, and we wanted to employ that in addition to taking care of the patients, is to identify what affects caregivers. Other outcomes which are critical to researching MSA were the motor outcomes, the UMSARS 1, UMSARS 2, UMSARS 3, which everybody is familiar with, mood, depression, and anxiety, and autonomic function. In terms of the educational core, Dr. Vernino started up the Autonomic Disorders Fellowship, a very prestigious training program in our MSA clinic. MSA clinic is a training ground for the fellow. The Movement Disorders Fellow trains at the clinic as well. Residents rotate through the clinic. Advanced practice providers get experience with treatment of MSA and recognition of MSA. There's community outreach being done to speak to support groups as well as to other community docs about MSA and associated conditions such as PSP, corticobasal degeneration, and of course education of patients and caregivers in terms of better treatment, in terms of troubleshooting certain conditions when they arise, in terms of dealing with depression and anxiety, etc. So we put together a team, and this photograph it shows you who the members of our team are, flanked by myself and Dr. Vernino, and I think this would be from your right to my left. Steve Hopkins, who is a research coordinator. Meredith Brierly, she is a first Autonomics Fellow. She is a second-year fellow. She did her first year neuromuscular diseases. Bernadette Latson, who is our nutritionist. Paige Palladino, who is our nurse coordinator. Lashandra Lara, who's also a nurse who supports Paige. Crystal Thompson, who is our MOA, Elizabeth Kent, our indispensable social worker, Cecilia Hernandez, our research coordinator. This is the core MSA team right now, providing care to patients and families in our MSA clinic. And without these people, I wouldn't be here talking to you about the Center of Excellence. And most importantly, funding for the center came initially from the largesse of the Reed family. Mr. Reed has MSA. He recognized the need for an MSA clinic and gave us starting funds to initiate the clinic. And of course, the Griswolds who are here, we are very appreciative of their efforts to support their clinics and continue to support them, support its functions. So just this timeline that I was talking about, the Center of Excellence took a significant amount of reconnaissance, of investigation. We approached the MSA Coalition for support. They gave us ideas on what patients needed, which was very helpful, what were the unmet needs, and they also basically gave us the green light to go ahead and do this because it hadn't been done before. So we were the first clinic that was going to establish a blueprint for other clinics, which we actually did. So now we have a manifesto for establishing centers of excellence, and I'm happy to say that my partner at Stanford, my colleague, Dr. Mupidi, who trained at UT Southwestern, is looking into initiating a similar center at Stanford using this very same blueprint. We looked at our database to see how many patients had MSA or possibly were diagnosed with MSA to get an idea of the numbers we needed to serve within our clinic. We talked to all the stakeholders, which were most importantly patients and families, but also within our clinic with our collaborators, the otolaryngologists, the cardiologists, and everybody jumped on board. And I was just surprised at how enthusiastic the entire MSA support group was in terms of collaborating with us in starting up this clinic. And then we formed our team MSA, and all of this before the funding, because we knew where there's a will, there's a way, and it was coming. So we got our team together, and sure enough, right person, right place, right time, Mr. Reed came along and supported our efforts, and here we are a year later. And we formed our first clinic, and it's been going great. The very first clinic was in September of 2015. So what I did is encapsulated the entire timeline in about 15 seconds, and it took about 8 months to get it together. So what does a clinic look like right now? Patient is obviously the center of our efforts, and there are all these subspecialty services that you can look at. Families are involved in the Center of Excellence. We highly encourage families to accompany patients, particularly caregivers. They're seen by all these folks in the clinic. This is the core group comprising the team MSA. We get internal referrals right from within the Movement Disorders Clinic and other clinics in the neurology department. And now we've begun to get external referrals from other states. People want to come to our center. It's gained some advertising, and it's become sort of popular now. And one of the most important things that we do after every clinic is have an interdisciplinary meeting in which all the experts get together in a room and talk about the plan of care for the patient. That is the definition of a true multidisciplinary clinic, in which people communicate with each other. And the plan of care then evolves, and we take everybody's input into consideration, and we have a final plan of care for the patient and the family. So in between clinics are absolutely wonderful social worker, clinical social worker Elizabeth Kent does teleconferences and webinars. She's done about 10, at least, in which various topics are discussed. Diagnosis of MSA, prognosis, communication, improvement of communication between patient, caregiver, and society. Role of the social worker in the care of MSA, estate planning, education of patients and family members, in terms of management of MSA, but also the utility and the importance of neuropathological diagnosis, home modifications, anger management, how to deal with MSA over the holidays. This was a topic that was requested by the patients. The importance of philanthropy. This is absolutely critical for the sustenance of our clinic, and the role of physical medicine and rehabilitation to improve mobility. These were just the topics that were discussed over the last year, and now we have separate caregiver conferences, separate conferences for caregivers as well as patients, and we hope they can be webinars. Thus far, there have been teleconferences, and this is really important because this gives us that much-needed feedback that informs our quality of life and the caregiver index burden. So out of the very first year, when we looked at quality of life of the 42 patients in our clinic, it was obvious that there are certain things that were a little more concerning than others, and they're highlighted for you. Greater than 50% of the patients complained of loss of autonomy, feelings of depression, and basically just loss of independence. Although there were several elements in the quality of life scale, this was what most people were concerned about. Were concerned about what impacted their quality of life. In terms of in terms of the caregiver index burden, this chart needs to be read from the far right to the left, the y-axis. The things that caregivers basically were concerned about were again, loss of autonomy, difficulty getting out of home because of a patient, because of the needs of the patient, etc. As you can read on the board. So, in addition to quantitative feedback, we are getting qualitative feedback from our patients. One of the first things patients identified were the clinic visits were too long. They were getting very tired. Autonomic testing in the morning, clinics in the afternoon. They were spending 4 hours in the clinic, and it was very difficult for them to do. And then we realized that we need to be practical. Not everybody can see everybody all the time. Let's have a needs-based assessment and have patients see perhaps a nutritionist on one clinic visit. 4 months down the road, let's see if they have rehabilitation needs. And most importantly, we are in touch with our patients in between clinics. So if patients and families need a visit to me in between clinic visits, they're more than welcome to come see me in the movement disorders clinic. It doesn't have to be a multidisciplinary clinic. So that was a very good thing that came out of talking to patients, and we shortened the visits accordingly. We need better mental health counseling was a common theme in our clinic, particularly among caregivers. And our social worker is fantastic, but she has only so many hours funded for her, so she did whatever she could. As you know, mental health services are scarce, not easy to come by, and not paid for. So this is one of the things that we want to do going forward in our clinic, is try to get a clinical psychologist in to address the needs of the patients and caregivers. Caregivers wanted a separate conference where they could speak freely with the social worker, and that's happening. We have 2 different conferences, one for patients and one for caregivers. And some good feedback. Most people thought the clinic was exceptional, and I'm sorry, the question which is on everybody's mind is, are you working towards a cure? And the answer is yes. When we start up our research for disease-modifying therapies, one of the main reasons we got patients together was to identify a well-diagnosed population of of patients with MSA. So when we are researching and doing research trials on MSA, the outcomes are not confounded by including patients who do not have MSA. And it's a rare condition, so we need to get various clinics together, form a consortium, and select people with MSA to study disease-modifying therapies to minimize the chances of patients with other diseases being included in that patient population. And one of the best ways to do that is to have a center of excellence and a multidisciplinary clinic. So at this point, I think I've spoken enough and taken enough of your time. I'm going to hand it over to Dr. Bernino, who's going to talk about the future and research, etc. Thank you.
I want to start by giving all credit to Dr. Kamani and to Elizabeth Kent that you heard about a lot, because it's a labor of love, and he's put a lot of heart and soul into it. So the clinic is doing a lot of good things, as you saw, and we will continue. But what does the future look like? We want to start to add the research arm to our multidisciplinary clinic, which obviously, hopefully, will include therapeutics in the near future. But as we talked about earlier, the importance of biomarker research and improving and ensuring an accurate diagnosis is going to be an important part of that. And then, the multidisciplinary care model needs to be need to continue to get feedback and improve, and we're really dedicated to the idea of gathering data from our patients, finding out what works and doesn't work, and really building and enhancing the blueprint of this multidisciplinary patient care model. All of these things, the research, the education, the clinical care, requires an infrastructure, and we're, again, working on establishing what the blueprint for the infrastructure of a clinical center of excellence looks like, for the goal of sharing that freely with all the folks around the country who have a passion for treating this disease and improving the quality of life for patients, so that there can be a multi-system atrophy center of excellence in other places. It's, as you can imagine, not practical for patients to come to Texas from Maine or Washington State. They're certainly welcome, but it may not be practical to get the ongoing care in that way. So there may also need to be a teleconference or virtual visit sort of model as well to deliver care to patients who are more remotely placed. So some of the new things that are coming on with respect to biomarkers, just to share with you what we're working on. We have an excellent colleague who's joined UT Southwestern from Johns Hopkins, who's an expert in PET scan imaging. And this just shows some of our early experience using PET scans to help identify and distinguish multiple system atrophy from other disorders. And if this pointer works, you can see this is a patient who has MSA type C, and if you know a little bit of brain anatomy, this is the brain, and on the back end of the brain is the cerebellum. A PET scan shows metabolism, so areas that are dark or purple or blue show areas where the metabolism of the brain is impaired compared to what it should be. So obviously this patient has a very low metabolism in their cerebellum, consistent with their symptoms of ataxia. But what's more interesting is that they also have impaired metabolism in what we call the basal ganglia. This would be in the same area where you might see low metabolism in Parkinson's disease. So we can see that on the PET scan. We probably wouldn't see that on a regular MRI scan. And even some reduced metabolism in the motor cortex, the corticospinal tracts. So this truly is a PET scan that shows functionally the underlying multiple systems that are involved, both the cerebellum, the basal ganglia, and the corticospinal tract. So we think that imaging studies like this, which are getting easier and easier to accomplish, may be a way to diagnose MSA very early, just as an example. So what does the future look like? What are we going to be doing over the next year? Well, we are right now looking at the outcomes and the impact of our first year with the MSA Center of Excellence. What have we done well? What can we do better? And of course, we'd like to be able to demonstrate that all this hard work has actually led to some improvement in quality of life and reduction in caregiver burden. We shall see. We're also looking at, again, biomarkers and ways to better understand the disease, better diagnose the disease, including using methods to quantitate what the gait looks like. You may have seen in Hollywood where they put on little sensors on the arms and legs and watch people walk around, and you can get a lot of information. And we believe that we can differentiate Parkinson's disease from multiple system atrophy because of some differences in the way people walk, and that would be early in the disease, of course. There is, as you may know, a global multiple system atrophy registry that's being organized, which hopefully will include all of the major players, and we are going to be part of that. That's in the works. PET scanning I talked about. This is really getting into the wish list now. Disease-modifying therapies are really the goal, and we hope that that's not far off. The MSA Coalition is a major player in funding pilot projects to investigate new therapies and new biomarkers, and we hope that as those come to fruition, that the Centers of Excellence can be the first to engage in clinical trials because we already have the infrastructure built. And we need to improve access because, as you might imagine, as we have a good product and we are delivering quality and improving quality of life, that more patients will want to come and we want to be able to accept them. That requires some funding, so tell your friends and your rich benefactors. And we obviously want to partner with the Multiple System Atrophy Coalition, but also to develop an MSA consortium. Those would be the various centers of excellence around the country as they come into being, so that we're all working together for a common goal. We're not reproducing the same effort. And hopefully, with our experience, we can help new centers to kind of jumpstart the process and skip over some of the bumps in the road to become an outstanding center of excellence even faster than we did. And with that, I am done, and on behalf of Dr. Kamani and myself, thank you very much for letting us tell you about it. Yes, let's start here. I'm sure all these questions are for Dr. Kamani, so he'll get you.
For a lot of us, the first point of reference when we're researching and find out about MSA, we go to the internet, and the MSA Coalition website is the first thing that we see. Is there a link or reference or endorsement for the Center of Excellence at UT Southwestern?
Well, actually, I think I can tell this story. When we sort of put this concept forward, really the idea was we had a concept, and we came to the MSA Coalition and said, tell us what a Center of Excellence would look like, and we'll build one. And of course they said, well, that sounds like a great idea, but we don't know what it looks like either. So maybe you can help. So we really, all of what we've been talking about now has really been the initial effort to try to figure out what a Center of Excellence looks like. And I believe that the next step would be to come back to the coalition and say, here's the blueprint. I think if you feel like you like what you see, maybe you want to put the stamp of approval on us and on future centers as well, so that exactly what you said would happen. You'd like to have a situation where patients could come to the main resource, the coalition, and make you see the list of which centers the MSA Coalition thinks are pretty good.
Clearly, your Center of Excellence and a reference to it would be so helpful for people who are just finding out about MSA and the new patients. I can see where it would be a tremendous resource for them.
I think part of our, as you saw, education was a big piece there. So I think part of our mission we perceive is that we have to engage with all the stakeholders, and a lot of times they're asking us to provide content. What are the frequently asked questions, and what are the answers, and so we need to build some of that in our material, but also to be able to not reproduce everything, but have links that go back and forth.
Thank you.
Okay. I believe that if people are listening at home on the web, they can call in. Is that correct? So it's a message board. So just so they know they can do that, we may be taking a couple questions from people at home also.
Over here.
Wow. You use terminology that I'm not familiar with, and I apologize for my lack of...
That's how doctors do it.
I got it. Okay. But I saw PET scan, and I've had 2 DAT scans. Are they the same or similar, or what?
Well, this is the guy to ask, but I'll take a crack at it. They're a bit different. I put up the picture because it's pretty. But, a DAT scan looks for the dopamine transporter, which is found a lot in that deep part of the brain. So it tells us whether there's a deficiency of dopamine in the striatum, which is that part of the brain that you can see in the middle there, that you could also see on the PET scan. So it's really a measurement of dopamine function, whereas the PET scan is a measure of general metabolism. So you could certainly have an area of the brain which is having normal metabolism, but perhaps deficient in dopamine. They give you a little bit different information. The reason we've pursued or been interested in pursuing PET scan is that a DAT scan itself doesn't really help you distinguish Parkinson's from MSA. They're both abnormal. They both have a dopamine problem. And that particular scan, although very good for differentiating Parkinson's disease from other types of tremor, isn't very good at differentiating Parkinson's from MSA, so we need some better tools.
One last thing, can you tell me if you have any opinions as to hereditary passage of this to family members?
You can jump into on this one. I think our general advice to patients is that we don't know of a convincing genetic link. There have been a few families, you may know about the issue of mutations in the CoQ10 pathway that were found in Japan. It doesn't appear that that's a common thing. So as of right now, I would say the vast majority, 99+% of patients have what we call a sporadic disease. It's not genetic. Now, as with anything, there's probably some genetic risk factors. So something about the way your brain is put together may put some people at higher risk for MSA than others. But there isn't one gene that seems to be passed along from families. So at this point, there's no special risk of patients getting MSA if they have a family member.
Hi, thank you, both of you. This is not a medical question. I'm wondering, at your facility, do you ever think there might be a living, a residential component? Because I imagine, I've talked to many people who would love to have a facility that just knows how to take care of us.
Yeah, I mean, I know where you're coming from, because this was, as you know, Alzheimer's is a much more common disease, and there have been a number of nursing home or skilled care kind of facilities that have really gotten good at taking care of Alzheimer's patients. And certainly there's a need. The problem again is that it's a rare disease, and we've been fairly successful in bringing together 40 or 50 of our dear friends to our clinic, but not the ability to invest in a care facility like that would be a major undertaking. It's a bit beyond what we as doctors know how to do, for sure, but it's an interesting concept.
It's something that comes up frequently, and we were probably discussing this earlier on as well with Larry, I think, about the residential component with the two things. One is the residential stay for people who are coming to the Center of Excellence overnight, etc. The other is just taking care of people. There's sufficient data now to show that the outcomes of most diseases, including neurodegenerative diseases, are best when people are taken care of at home. And what we need to do is a hub and spoke model in which centers of excellence or an MSA consortium can allow that to happen in areas where people don't have access to such centers of excellence. And we can do that through telemedicine. We can do that through annual visits. We can do that through, it's critical to have social workers help navigate the healthcare system, as I was talking, and help people locally and in remote areas. So you don't necessarily have to have a residential facility. It can be done remotely through these centers of excellence. And that's one of the missions of a center of excellence, is to basically potentially take care of people in remote areas that are not close to a center of excellence.
My question is, back here in the corner.
All right, but then Freddie's next for sure.
Okay.
Okay,
Sorry, Freddie. We was back here. Sorry. I'm interested in knowing, how do you run your interdisciplinary clinic? How is it actually set up? And how often, like how long is your clinic visits? Because I know you made a comment of patients saying that they're there too long. They don't want to be there 3-4 hours. So interested in understanding how that's set up and with space constrictions.
All right, well, again, this is much of what Dr. Kamani and his team have done over the years is to work out this model, because there's a lot of moving parts. And what we try to do is have a very somewhat complicated schedule, such that patients, as one person comes out, the next one's ready to go in, and so there's no wasted time in the clinic. And again, trying to figure out who the patient needs to see at that visit and scheduling them in. So the whole visit itself, I think our current model is that patients come in about 12:30, get checked in, the nurses do their thing, and so starting about 1 o'clock or 1:15, they start seeing people, kind of one after another, maybe a few breaks for catching their breath, and we try to wrap it up around 3 or 3:30 when they've seen everybody. But those patients that are there and really need to see everybody, it may run a little longer. Those are coming to follow up, and they really have specific things. We can hopefully schedule it so they're done a bit earlier. So that's the way we're doing it, and that's really, again, the nurse coordinator actually doesn't see any patients. She's just sort of directing traffic and making sure as I walk out of a room, she says, now you're going into room 3. And that's really the crux of making it all work right.
We also, as I was telling you, take care of patients and family members in between clinics. Right, so that's actually very important, is to address unmet needs that maybe could not have been discussed with the physician or the social worker or anybody in clinic. So the nurse coordinator and the social worker have follow-up phone calls with patients and family members as well.
Finally, are you aware of any other medical facilities in different cities in the U.S. that are looking into setting up a center of excellence?
Well, in the West, did you say?
Anywhere in the U.S.
In the U.S. So as Dr. Kamani mentioned, one of our colleagues who actually trained at UT Southwestern is now at Stanford and has a great interest in pulling this together. I think is in what you call the reconnaissance phase of bringing together the players involved. There's a few other clinics around. I know of one in the University of Florida, which is sort of a scaled down version, has a doctor and a physical therapist. That's not quite a center of excellence, but it's at least 2 parts of the multidisciplinary care. And there's probably a few things like that. So I don't know of any that are sort of ready for prime time. But if you have some local physicians that are interested, have them give us a call. We'll certainly help provide some guidance and motivation to move it along.
Thank you.
Okay, we're going to take a couple more. I know we have one from back here in the back, and then we'll take one more question. Hate to cut it off, but we have a couple other things to wrap up, and we want you all fresh for tomorrow's session.
I know there seems to be a lot more research about the microbiome and its relation to the brain. Are y'all beginning to, I know the gastro was on there, are y'all starting to tie that in some ways?
It's you know about the microbiome? It's fascinating. For those of you who don't know, there's one statistic I heard that if you look at all the DNA in someone's body, only 10 or 15% of it is actually your human DNA. The rest of it is all the microbiome that's living in you, which definitely influences, for sure, the immune system and probably a lot of metabolism and a lot of other things. I think it's a whole major area of research that I'm not that familiar with, but may play a role here. I mean, there are some theories about, how does alpha-synuclein get started? Does it start in the gut somehow and then spread to the brain? A lot of theories. I'm not sure I've seen convincing data to give us the answer, but there are certainly people working in that area.
Yeah, I agree. It's a little more researched in Parkinson's disease than in multiple system atrophy, because Parkinson's disease is more common, and there's this whole theory that the alpha-synuclein travels from the gut up the vagus nerve through the brainstem, and people who have had vagotomies or their vagus nerve has been clipped tend to have a lower risk of development of Parkinson's disease, but the data is sort of nebulous, and the vagus nerve performs a very important function, particularly in MSA, so please don't explore that option yet.
Well, I thank you all for your questions. I thank the docs for their Yeah, but I think you were going to introduce her?
Oh, was I? Okay.
Somebody was.
I give you Richa. That's all I know about her.
Okay, we're going to bring Cindy up then. I was under the impression that Docs were going to introduce our next speaker, but we're winging it, folks. We just hope you enjoy it. So we offer comic relief as we do this, so.
Okay, so we're going to move on to the candle lighting ceremony. As Judy mentioned earlier, we started this recently. It's new to our program. Last year, the conference fell on the weekend of MSA World Day, so we decided to follow through and do this ceremony, and it was really a lovely touch to recognize those traveling the journey or those who have traveled the journey. So we're going to continue with that ceremony this evening, and I just want to give you a little bit of information about what we're going to do. We do have someone to facilitate that's going to come up and speak. After she does, then we have a few special dedications this evening, and then we're going to turn it over to you, and what we're going to ask you to do is for one member of your party to bring up the card and the little dedication that you wrote, and you'll bring it up to the table with the candles, which is in the center here, sort of behind that column. There's candles there, and they are real candles, so we do have somebody that will be there staffing it to actually light the candles as you place your card in honor of your loved one. So to facilitate this ceremony, we have a very special guest this year, Richa Shupa Moons, and she lost her husband Jaipai in 2009 to MSA while he was still with her. Together as caregivers, they began to share information with others and to help them. They formed MSA Belgium, and she has been a great advocate in the MSA community. She is one of the driving forces behind World MSA Day and the initiator of Mile and a Candle for MSA, which is now known as Walk, Run, or Cycle and Light a Candle for MSA. So we are very, very happy to have the actual initiator here with us tonight. So I'm going to turn this over to Richa Shupa Moons. Thank you for being here with us tonight.
Thank you, Cynthia, to give me this opportunity to lead the candlelight session. But first, I like to share a little movie to explain the reason of being here and the promise I made. It was an interview in my home language, Dutch, but I made a photo slide with English text overflowing. So now you will read everything that happened since he passed away. And a lot of this is also with the people here around me. We had the first MSA day. The first GP award was in 2011. We had the first Mile and a Candle. In 2030, it became Walk, Run or Cycle for MSA. And last year, we were able to go around, even more than around the world. So thank you for everybody that helped us. And I hope that this year we still can catch the same results. We are behind, but we still have the rest of the month to go. And as we start lighting the candles later on, we have extra candles as well. But I like to misuse a little bit the time I get here, because we have the GP award. Who is getting a GP award? That is for special people, or in research, or people that do something extraordinary. And last year, in 2015, there was a GP award awarded to Bob. So, can you come along, please? So last year, he was rewarded, but something happened. When we were sending the award to him, it disappeared. After 6 months, it didn't turn up. So we have remade the award, but by the award there is also a little paper. And we are lucky that we have a good godfather in our country, and for the moment he is the Deputy Prime Minister and Minister of Interior Affairs. So he had to re-sign the document, and it took ages to get it with us. So, Bob, I would like to hand it over for you and Susan as founders for the March Award this month. So, this is the paperwork. This is the beautiful award that never ends up, and at least now you have it first-handed. Congratulations.
I'm not much at giving a speech, but I have a story. Susan, who is of course not with me, she passed away May the 4th of 2012. The reason that I get out and try to raise awareness and support so many of those of you who I have an opportunity to drop in and see as I travel, all started with Sue. In 2005, she had a trach and a feeding tube. And in, I guess, the spring the following year, she asked that we go and visit this lady and her husband in Jackson, Tennessee. That's about 3 hours, 2.5 hours from our house. This would be the first time that we had made any extensive trip away from home. And I said, Sue, do you know what you're asking? And she said, I want to go see Alice. Now, she communicated with me through a communication that we had. She couldn't speak, and it was all eye movement, and we had a little card that we had memorized so that if we were ever out somewhere, we could communicate, and even at home. And so she emphasized that we go see Alice again. Now, Alice had MSA. And here she is with a trach and a feeding tube on our first trip away from home. And so she goes and visits with Alice for about 2.5 hours. Sue couldn't speak. Alice could, and I can remember that Alice placed her hand over on Sue's arm for that 2.5 hours, and that was a visit. And I thought about that a lot after we did it, but the trip we made fine, and when she passed away, I thought, what can I do? And I thought, Sue set the example. She was very much concerned about getting the awareness out, but she was also concerned about the people who was on the MSA journey. And she wanted to support. And I thought, what better for me to do than to continue something that she had helped me to learn a lesson about. I was a 24/7 caregiver from 2003 to the time that she passed away. And so the journey, like you, we had something in common that we all worked toward. And I thank you for this. And all of you, God bless. And keep the awareness going. You doctors over there, that's great what we heard tonight. And hopefully more and more good things will happen for our people.
Thank you, Bob, for all you do. At this time, Rich is going to go ahead to the table and light the first candle of the evening. And as I said, we have a few special dedications. So at this time, I would like to ask Larry Kellerman to come on up to the podium. Larry? Here he comes. Larry Kellerman is a member of the board of the MSA Coalition. He's been an educator for 30 years in the sciences, and when his late wife, Colleen, his angel, was diagnosed with MSA, he retired early to become her full-time caregiver. They were married for 17 years when he lost her in February, and he is actually our first ever caregiver representative on our board, elected to the board in 2014. And we also at that time had Tom Looney, our first ever patient representative on the board at that time. And Larry's going to say a few words about Tom. Thank you, Larry.
Yes. Thank you all for coming. I have to say I had not heard Reach's whole story, but watching it, my wife and I paralleled her so much. And the reason why I'm here, the reason why I work every day, is because she made me do the same mission as well. So I think sometimes our spouses are a bit more powerful than we give them credit for. And I'm really glad to find out I'm not the only one. I would like to talk about Tom Looney for just a couple of minutes. Tom and I came on the board at the same time. We began communicating by email when we were first nominated, which would have been a month and a half, 2 months before the actual election in June of 2014. We both shared a similar love, although his was more occupational and mine was more dream. He was a Division I college basketball player, and I always wanted to be a college basketball player. And he played at Mount St. Mary's in the mid-'80s. He was a standout basketball player for, at that time, turned out to be the winningest basketball coach since passed by other coaches, but Coach Jim Phelan was his coach. And he had a work ethic before. Jim Phelan taught him that that work ethic should follow you all the way through life. And from that time until he was diagnosed, he worked himself through a number of technology companies. He worked for Apple, worked for Steve Jobs. He worked for several other companies before he finally settled with Microsoft. And he was working at Microsoft when he began to show the symptoms that ultimately became MSA Parkinson's. He was diagnosed in 2007, and he began his journey with his wife, Trish, and at that time, 2 younger sons. And between then and now, he has been a most dedicated patient. He did exercise until recently, 6-7 hours a day. He was very, very dedicated. He felt that if he kept himself healthy and he used the discipline he'd learned as an athlete, that he might be able to, as I would say, defeat the beast. And unfortunately, over the 2015 time frame, he began to weaken, as many of us will find out, and others have already known, the beast doesn't give up. And so at the end of 2015, he decided he had better resign because he just could not support his mission, which was to provide the best service possible for patients and caregivers who needed the help and support that he was able to give. So in the meantime, he had done several things for the coalition that were really quite helpful for fundraising, for raising awareness. The one that he and another gentleman that will be up here in a few minutes, Don Kraus, started was called One Less Thing. And his idea was simple. He said he came up with it when he was traveling back to home and thought about what could we do to raise monies. And his idea was come up with a 30-second video, and in that video, tell your story about how you could save dollars and donate those dollars to the MSA Coalition for a research fund by doing or having one less thing. And a couple of these examples were you could have a video that would show you as a family watching a movie on television, and your statement might be, I'm doing one less thing, we're not going to go out to the movies for a year, and that money is going to be going to the coalition. He talked about maybe people would wash their cars in their driveway instead of going to the car wash, and one less thing would be getting your car washed at the car wash, and that money could come to the MSA Coalition. And so he came up with this idea, and we put it into play toward the end of 2015. He was hoping it would catch fire, which unfortunately it did not catch as much fire as we had hoped. But the idea is still there, and maybe out of what you all hear tonight and see between now and tomorrow afternoon, maybe you'll go back and say, gosh, that's a darn good idea. Why don't we start it, and why don't we see if we can carry that mission forward? I guess the other part is he and my wife got to be really good friends through a meeting at the Coalition Conference in 2014. And they had emailed back and forth, but Colleen and Tom got to be pretty special friends. They emailed, used MSA buddies through Facebook, communicated with each other, and toward the end of 2015, when my wife started declining to the point where, as Cindy said, she passed away earlier this year, he was a very good backbone for both of us. And it really struck home with me. And so this summer I've been communicating with him when I can and when he can. Sometimes it takes him a couple of weeks to be able to get back to me. And his trips have decreased. His ability to get out of the house has decreased. And in an email the other day, he was telling me about a couple of symptoms that are just really beginning to ramp up that he's kind of worried about. And his wife, Trish, is there to make sure he's taken care of. He downsized from a larger home to a smaller home. He's done everything he can to forestall that decline that will ultimately be the end of his MSA journey and the beginning of Trish's caregiver MSA journey. I asked him what were a couple of things that he lived by that would help maybe some of you. And he gave me two of them. One was, you have to have the philosophy, win the day. If you can win the day, and you say that every morning when you get up, and you've made it to the end of the day, and the next morning you say, win the day, you've accomplished what any patient would want to do. And Trish is there to help him win the day. And the other statement he used, and I found this in a interview that he had with one of the local newscasters in Wilmington, North Carolina, which is close to where he's from. And in that little interview, the way he stated it was, accept the diagnosis, defy the prognosis. And I think that, as much as Win Today, says a lot about Tom Looney and says a lot about, hopefully, the philosophy that maybe many of you who are patients will attain to as you make your journey. And so for Tom, we'd like to say, hold on, be strong. To Trish, keep Tom strong, be with him, give him the hug when you can. And most importantly, Tom, know that we're all here for you. So I thank you for letting me have the time. And remember Tom Looney whenever you think about patients and patients' representatives. He's a powerful human being for all of us. Thank you very much.
Thanks, Larry, and a big thank you to Tom, who hopefully is maybe listening at home. I'm here to very briefly read a little something about one of our board members who dropped off the board, just resigned from the board. She's healthy and well, but I have a question first of all. How many of you in the past have had an opportunity to meet Vera James? Okay, oh gosh. Maybe 15 hands or so went up. How many have had the opportunity to speak with Vera on the phone through the toll-free support line? Okay, another 10, 12 hands. So that's who I'm here to honor tonight. Okay, so this is for Vera. Have you ever met someone that you bonded with immediately and became best buddies with, even though you live 2,000 miles from each other? Someone you could talk with and share the good and not so good things that were really happening in your life? Someone who put you at ease, someone who really, really cared for you and how you were feeling? Well, I have. Many years ago, about the turn of the century, I was fortunate to link up with Vera James through the Shy Drager support group. Both of our husbands had MSA, and we became phone buddies, helping each other as we walked this MSA journey with our husbands, trying to smile through the everyday ups and downs. Caregiving was second nature to us. Both of our husbands died in 2003, but that did not end our friendship. It was the catalyst that cemented our friendship forever. In 2004, the annual patient conference like this one was held in Ohio, my home state. Vera was traveling from California to attend, and I drove north to meet her in person and attend my very first multiple system atrophy conference. Needless to say, Vera roped me into helping with some of the tasks, but I also got to see firsthand how she interacted with the patients and caregivers. She shared her knowledge of MSA, both what she had gleaned from literature and what she had learned from being Fred's caregiver. All the patients and caregivers departed that conference with more knowledge of MSA, but more importantly, we all left with a special bond with each other. Vera was the glue that would keep everyone connected via the internet and phone over the next few months and years. Vera became an official member of the board of directors in 2004 and later became co-chair of the board for several years. Vera was the patient caregiver coordinator and accepted the daunting task of answering the support line for the coalition. She co-facilitated a webinar in Southern California, bringing MSA to the attention of so many others. She worked with the Yahoo email group to keep people connected with other MSA patients and caregivers. This ensured patients and their families had access to much-needed medical information and to the human aspect of being able to converse with others on this MSA journey. Vera worked nonstop during the next 12 years, continuing to answer the support line, continuing to reach out and touch the hearts of patients and caregivers alike. Earlier this year, Vera stepped down from the MSA Coalition Board of Directors to become a more active caregiver to her elderly parents. Her father passed away recently, but her mother is still alive and in need of care. So once again, Vera is becoming the caregiver extraordinaire. Vera is unable to attend this year's conference, ending her attendance record that began in 2003, but we could not let the conference proceed tomorrow without acknowledging all that she has done for the multiple system atrophy family in general and for the MSA coalition in particular. Now, before we proceed with the candlelighting ceremony, please join me in sending Vera our heartfelt thanks and a big MSA family across the miles hug. We love you, Vera. Hugs from New Orleans. Thank you all, and thanks, Vera. Dawn is going to have a couple of announcements, and FYI, one of my little messages is going to be for Vera's husband, Fred, who can't be here. Since she's not here, we're going to light a candle for her husband. Thank you.
So tonight I actually have the honor of making a surprise tribute and recognizing somebody incredibly important to the multiple system atrophy community. As some of you may have heard, and some of you probably have not, Judy Biedenharn has decided to retire from the MSA Coalition and from her service to the to the MSA community. Judy has been involved in the community for a very long time. Her husband Ned was diagnosed in 1991 and passed away in 2003. During that time, she supported local support groups in her own home, I believe, in Ohio. And after his death in 2003, stayed connected with the community and decided to join the Multiple System Atrophy Coalition board in 2008. So she's been serving now for almost 9 years on the board and has resided and presided as president over a tremendous period of growth for the MSA Coalition, a time that saw amazing change for this organization and a time that I think is bringing new hope to the MSA community. In 2011, our board was Vera, Judy, and I, and we decided that it was time to really make an impact and to change the organization so that it was an organization that could really represent the community. So we changed the name from the SDS MSA Support Group to the MSA Coalition at that point, and we decided to start a dedicated multiple system atrophy research grant program. We recruited a scientific advisory board. Dr. Bernino is a member of that board, and in the years prior to 2012, the MSA or the SDS MSA support group was raising $15,000, $20,000, $30,000 a year if it was a good year, and we were struggling to even do meetings that were a quarter of this size. And we were primarily doing these annual meetings and manning the support hotline. Our former president, Don Summers, manned that hotline for many years before Vera took it over. And those were the services, excuse me, those were the services that we were providing. So we decided to expand our mission, and so the new mission included those services, but also put a huge focus on funding research and really trying to make an impact in terms of finding a definitive cause, finding a biomarker to diagnose the condition earlier, to find treatments that can either slow it or halt the disorder, and ultimately to find a cure. We also wanted to provide great education to patients, to physicians, to other healthcare providers so that diagnosis and treatment could improve. And also to be an advocate. So we started traveling to Washington, D.C. and advocating for issues that were important to rare diseases, as well as specifically to MSA. So all of that has happened in the last 4 years, and we went from, as I said, an organization raising $10,000, $20,000, $30,000 a year to raising $50,000 in 2012, and we were all blown away. And then in 2013, we raised $200,000, and we were all blown away. And in 2014, it was, 2014, it was $500,000, and we were really excited. And then last year, for the first time, we got to announce that we'd raised over $1 million. So as you can see, it was just... Thank you. So Judy has served a remarkable tenure as our president, and it's with great honor tonight that I'd like to thank Judy on behalf of the MSA Coalition and our board, but also the entire MSA community for her passionate, dedicated service to this cause. And Judy, if you could please come up. Here's a crystal that I hope you will cherish. It says, with gratitude to Judy Biedenhardt for her many years of dedicated service to the MSA community. I'd also like to say that we will also be sending very similar crystals to Tom and to Vera James as well. Since they weren't here, we do not have the plaques with us. But you can see this is also a sign that we're getting bigger. We can actually do plaques now and honor people who deserve it. So thanks, Judy.
I've been at the microphone too much, but it's been a long journey, but a nice journey to travel with people like you, so many nice people. And even though I might not be officially on the board, you'll see me at future conferences, but I'll be sitting out there with you, not running around crazy. So thank you all so much. And I think now we're probably getting ready to go on with the candle lighting ceremony. But before I do, tomorrow morning, breakfast is at 8 o'clock, and it's over in the other building, the main building. So don't come over here. It's over there in Salon D, I think. So don't be late. We'll feed you, and then we'll try to educate you a little bit more. But thanks so much for all this. I could not have done any of that. I mean, it wasn't me. It was the board and all the new people that have come on the board since then. We've really bonded as a team and as a family, and they deserve this. It should say Judy Biedenhardt et al. That's for sure. Thank you.
Thank you, Judy. Before you run off,
for one last quick second. As some of you know, we've been trying to do some videotaping. We have a videographer. Tomorrow he's going to be in a different location. But I'd just like to announce that if you're interested in having a one-on-one interview with a videographer, you can do it as a group or as an individual. We're going to be using these videotapes to create very important videos to help with our awareness and to boost our fundraising efforts as we head into the holiday season, which is by far our most critical time of the year. So if you're interested in potentially working with the videographer tomorrow, we have some time slots open. Please feel free to come up to me and I'll figure out a time that works for you to get in and do that. So thank you very much.
thank you, Don. Okay, so now we are ready to go on with the candle lighting ceremony. We're going to start, as you heard the history here, the board is all volunteer, okay, totally volunteer, and we're here because we were all touched by MSA. Our lives were touched by loved ones who traveled the journey that you're traveling now. So we will begin the candle lighting ceremony. Judy, are you going to say a couple of words about that? She's going to light a candle on behalf of our loved ones as members of the board, and then once she does that, we're going to ask again a member of your party to take your cards up to the table, and we'll get those candles lit in honor of everyone who has and is now traveling the MSA journey. Judy?
Tomorrow morning, candles being Okay, I'm not going to say anymore. Just a couple people, my husband, Vera's husband, and all the members, spouses of our board members who have passed away. That's in memory of them. So thank you. Thank you.
Thank you. Okay, everyone, please. There's no order to this. We just go ahead and come on up, go to the table, and honor your loved one.
If you'll pardon me, folks, I'm going to share some music with you for a moment. It's in my heart to share this with you, so bear with me. Hum along or sing along. And know that I have a little bit of a problem here, so bear with me. Thank you.
Prior to 2003, prior to 2003, 2003 it was in San Diego. I did not attend. My husband had just passed away, but I'm not sure exactly how long before that. So, okay. With the candle lighting ceremony over, that kind of concludes our official program. I know it's been a long day and it's going to be a long day tomorrow, but you're welcome to stay and visit if you feel up to that for a few minutes. And if not, we'll see everyone about 8 o'clock in the morning for breakfast in the other building. Thank you.